You never close your eyes anymore. Oh, hello. Look, it's Mel Herbert here for EMRAP. Look, we have an EKG episode coming up with the Amomatu, talking about a 28-year-old with syncope. Do you have a clear differential diagnosis of what to look for on the EKG in a young person that comes in with syncope? Do you? Well, you're about to. Ladies and gentlemen, Amomatu is going to teach you up good. Now, remember that this is EMRAPTV. It is the free part of the EMRAP program. But the meat, the chunks, the goodness, the bundt cake-infused loveliness is found at EMRAP.org. Our 4 hours a month audio series with board review, CME, and all the loveliness that any person could possibly desire within emergency medicine. Ladies and gentlemen, boys and girls, Amomatu.
Well, greetings everyone and welcome to the EKG case for the week of June 3rd, 2012. Got a simple case, or relatively short case I should say, for you. It's a 28-year-old woman that presented to the emergency department recently complaining of syncope, and of course we're going to get a 12-lead EKG, otherwise we wouldn't be here in the first place, right? So here's the 12-lead EKG, and I'll give you the computer's interpretation there as well. It's called normal. You take a look at this EKG for a few seconds. Now, what are you looking for when you get the 12-lead EKG on a young person with syncope? Well, normally we're looking for ischemia in most patients, maybe less concerned about ischemia in a 28-year-old woman, especially somebody who has no risk factors for cardiac disease, which this patient did not have any of those. We're also, of course, going to worry about tachy and Brady dysrhythmias, but there's a few other things that you've always got to look for in the EKG of somebody presenting with syncope. One of the things that you've got to look at in every EKG, especially the syncope EKGs, is the intervals. Because if you don't take a look at those intervals, you're going to miss some critically important diagnoses. And when you look at the intervals, well, we'll take these one at a time. Of course, you're going to look at the QT interval. And the QT interval is actually pretty good, the QT and the QTC. The QRS interval looks pretty good. It's less than 100 milliseconds, so that's pretty good. But the PR interval is what's abnormal here. A normal PR interval should be 120 to 200 milliseconds. This one is a short PR. And whenever you see a short PR, there's two things you've got to think about. Number one, you think about junctional rhythms. Junctional rhythms can give you a short PR or simply no P wave. But a short PR, you think about junctional rhythms. And then the other thing that you've got to think about, especially in syncope patients with the short PR, is you've got to think about Wolff-Parkinson-White syndrome. And that's what this is. So I mentioned this is a relatively simple case, but maybe not quite as simple for the people taking care of this patient, who initially relied on the computer interpretation to call this a normal EKG. And you kind of look at this and say, why is the computer missing WPW also? Well, very simple. Because if you look at all of these leads on the 12-lead EKG, everyone is looking for delta waves probably now, and everyone's been trained that WPW produces delta waves. If you're in the habit of always looking for delta waves as your means of diagnosing WPW, I promise you, you're going to miss some cases of WPW just the way this computer missed WPW. Because delta waves are not present in all of the leads. What is present in all of the leads is that short PR. So please remember to look at the PR interval, and when you see a short PR, let that be the tip-off to now start diligently looking everywhere for delta waves. And now that you're looking in all 12 leads for delta waves, you notice that there's a delta wave in lead 1. You notice maybe there's a delta wave in V1, and maybe just a hint of it in V2, but definitely V3, V4, not even so much in V5, but look at what I've circled. Of the 12 EKG leads here, only 4 of those leads really show nice delta waves that are going to catch your attention. So that's why I say if you're in the habit of looking for delta waves, you're going to miss WPW, because most cases of WPW don't show delta waves in all of the leads. And if you happen to look at the wrong leads, you're going to miss WPW. All right, as the computer did here, and as the physician taking care of this patient initially did as well. So how are you going to pick up WPW? the one incontrovertible finding for WPW is going to be that short PR interval. So when you're running through the 12-lead EKG of every patient, especially EKGs on the boards and especially EKGs of syncope patients, always take a specific look at the intervals, and when you then see a short PR, that will be your tip-off to now go and start looking in all 12 leads for delta waves. And when you do that, you'll pick up the WPW. All right? If you don't do that, you're going to miss it. So just a brief rundown of what we're looking for in the EKG of post-syncope patients. Everybody looks for ischemia. Everybody looks for tachy dysrhythmias, Brady dysrhythmias, and AV blocks. But the other can't miss things you've got to look for on the EKG of syncope patients: WPW, long QT, hypertrophic cardiomyopathy, Brugada syndrome, and arrhythmogenic right ventricular dysplasia, which is not that commonly diagnosed on EKG alone. We'll talk about it perhaps sometime, but it's not that common, especially in the United States. And I want to point out specifically two things here. If you don't get in the habit of always looking at the intervals in your EKGs, especially your post-syncope EKGs, you will miss WPW, you will miss long QT. You've got to look, hopefully you're getting bored of me saying this, but I don't care. You've got to look at the intervals in every post-syncope EKG, because if you don't, you're going to miss WPW and you're going to miss that long QT also. All right? So when you see the short PR, let that be your tip-off to now start going and looking for those delta waves. If all you're doing is looking for delta waves right off the bat, you're going to miss it, because delta waves are not present in every one of those 12 leads. Let the short PR be your tip-off. All right? So short case, kind of a nice case. Don't miss WPW. Look at the intervals. In every post-syncope EKG, I've said it 100 times now, look at the intervals. That makes it 101. Hope that was helpful, and I will talk to you next week. Bye for now.